Deprescribing Medications in Geriatric Patients. This presentation was created by Rebecca Brynjolfsson. The objectives that we will meet by the end of this presentation are to identify the factors that should be considered in medication deprescribing, identify instruments available to guide decisions related to medication deprescribing, and identify some recently published journal articles that can help to inform providers of patients that may either benefit from medication deprescribing or perhaps give us more evidence to keep patients on medications that we might not otherwise have had evidence to consider. Let's start with defining deprescribing. The definition is from the article Deprescribing in Older Adults with Cardiovascular Disease. They have indicated that a comprehensive definition of deprescribing should include an organized process of medication removal or dose reduction, oversight of the deprescribing process by an appropriate member of the healthcare team, a goal of improving one or more specific outcomes, and consideration of an individual's overall physiological status, age of life, and goals of care. In what situations should it be considered? It would be appropriate to consider deprescribing if a patient has had, or if you're anticipating they to have an adverse drug reaction to medication. It should be considered in polypharmacy. There are several definitions of polypharmacy, but most would agree that would be in situations where there are 5 or more medications prescribed, which happens frequently in our older adult population. Prescribing cascades would be where one medication has been prescribed as a result of a patient potentially experiencing an adverse effect from a medication that was previously prescribed to them. In end-of-life or palliative care, it would be appropriate to consider deprescribing as well. What are the steps involved in deprescribing? First of all, it would be important to conduct medication reconciliation. It takes time to get an accurate medication list from patients. Often, patients may not always be forthcoming with what they're actually taking. Our prescription medications are fairly easily reconciled based on the electronic health record, but capturing some of those over-the-counter or natural products used may take a little bit more time and effort after you complete a medication reconciliation or review. Assess the likelihood of a patient experiencing adverse effects of each medication prescription or over-the-counter product. This can be quite time-consuming. Consider if medications can be discontinued. If a medication can be discontinued, prioritize how this will occur. Typically, it would be recommended to discontinue one medication at a time. Discontinue medications as appropriate, and then monitor. Those are the steps for deprescribing. This is a very time-intensive process, which is one of the barriers to actively considering medication deprescribing in a comprehensive way for patients in the clinical setting. I have the 5 M's listed here as a framework. Consider mind, mobility, medications, multimorbidity, and what matters most. This can be a framework used to help you make decisions related to deprescribing. There are a lot of different instruments available to guide decisions related to deprescribing, but the evidence for deprescribing is really lacking in a lot of areas. Patients who are older adults have typically not been included in a lot of clinical trials that have shown either long-term benefit or risk for using specific medications. We have both implicit and explicit instruments that can help guide our decisions related to medication deprescribing. Some of the implicit instruments include the SMOG or screening medications in the older adult user by the Medication Appropriateness Index. There's a whole list of them here, and they all cover different drug-related problems. Not all or any of them are a comprehensive drug-related problem review. They all have pros and cons. All of these implicit instruments do require clinical judgment as well. The ACOV, or the Assessing Care of Vulnerable Adults, 3 is the only one that does not require as much clinical judgment to administer. All of these have been validated in the literature, with the exception of SMOG, the screening medications, and the older drug user. There are also some explicit instruments that give recommendations or things to consider for providers when considering deprescribing. These include the Beers criteria, Stop and stop freebies are often built into electronic health records to help alert prescribers as well to potential inappropriate medications that are being prescribed or have been prescribed to identify those that can be put into databases. Recommendations can be pulled from using these explicit instruments. There are barriers to conducting deprescribing in the elderly population. The COVID pandemic has added additional barriers to this. There's an article that's recently been published in the Journal of Research in Social and Administrative Pharmacy that talks about these barriers in the Canadian patient population. They talk about barriers that existed for deprescribing before COVID-19. Patient-focused barriers and system-focused barriers are the two things that are discussed. Patient-focused barriers include simply change, or not knowing what change will bring. Will it make things worse for them? Will they feel like their symptoms aren't being adequately controlled? Change is a hard thing for all people. Also, an understanding or knowledge related to what deprescribing is. Patients who are taking some medications that you may recommend for deprescribing may have been taking them for a long time. They don't want to stop taking them because they perceive that they're receiving benefit, even if that benefit may not be true. There's a lack of knowledge about what deprescribing is. Education for patients can help remove that barrier. There's concern among patients about removing medications versus replacing medications with alternative therapies. There are also system-focused barriers. Coordination of healthcare and the sharing of healthcare information can create barriers to deprescribing. Looking at the system that we have in the United States, our pharmacies, where medications are being dispensed, are not integrated with an electronic health record that can communicate or can allow all providers, including pharmacists who are filling medications and providers who are prescribing medications, to see the same type of information, which would help guide recommendations related to deprescribing. There are prescriber factors, whether prescribers want to consider deprescribing for patients or have experience with deprescribing. There is simply limited guidance and evidence in both clinical practice guidelines and in the literature related to this patient population. There are also some barriers that are specific to the COVID-19 pandemic and will likely continue to be barriers unless they're appropriately addressed. One of the patient-focused barriers is technology and virtual healthcare. Patients who are older adults may not have the knowledge and/or the technology to be able to access healthcare in a virtual environment. There is a lot of change going on right now for patients already. Starting a conversation about deprescribing or making changes may be simply overwhelming for patients, where it may not have been the case prior to COVID. With virtual healthcare, how are patients able to access healthcare? There are a lot of things to consider when deprescribing. The thing that we like to have is published literature. We like to have evidence to support our decisions, to guide our clinical reasoning, and to be able to rationally decide whether certain patients should be considered on or continued on therapies, or if those therapies should be discontinued. One of the areas that seems to have the least evidence is primary prevention. Let's focus on talking about some of the recent published literature related to statins and primary prevention. There will be some other trials that are coming out in upcoming years that will help to add some clarity to the discussion that we have today. When we talk about statins as a whole, and we talk about primary prevention, or even secondary prevention of cardiovascular disease, there is a lot of evidence. This is one of the areas that we probably have more evidence than anywhere else for what patients should be receiving as a standard of care. When it comes to older adults, the guidelines don't provide much guidance beyond age 75. Beyond age 75, it becomes a decision between the patient and the provider what would be most appropriate for that patient. There's little evidence to guide what the recommendations would be. At the time of all the major cardiovascular trials, elderly patients or older adults weren't included in the trials. They were excluded. We have a whole population of patients who have been started on primary prevention in the age range that we would consider to be acceptable or recommended. At this point, up to 75 who are going to become older than 75. The question will be, do they continue on a statin for primary prevention, At what point do you consider deprescribing a statin for those patients? There's a lot of evidence that will be coming, and the evidence that we have now is a lot of looking back at what has previously been prescribed. The first article that we're going to talk about addresses this issue: association of statin use with all-cause and cardiovascular mortality in U.S. veterans 75 years and older. Let's start with the author's overall conclusion and some background information. We'll also talk about some of the study characteristics and patient characteristics that were involved in this trial. The author's conclusion is quoted on this slide. Among U.S. veterans 75 years and older and free of a CVD at baseline, statin use was significantly associated with a lower risk of all-cause and cardiovascular mortality. Further research, including from randomized clinical trials, is needed to more definitively determine the role of statin therapy in older adults for primary prevention of ASCVD. This trial was looking at claims data for patients that were at the Veterans Health Association or Veterans Healthcare Association. This data was collected between 2002 and 2012. This will impact some of the recommendations that were made for therapy for these patients. And we see that most patients in this study, about 85% of the patients, were on simvastatin at the time between 2002 and 2012. It's important to remember that Crestor didn't come onto the market until 2003. It would have been brand only, and Lipitor did not become generic until 2011. This is typical for this time period for treatment, but it may not represent the types of statins we would see more commonly recommended and prescribed at this time. This study went through all the patients that had been active in the VA system for 2 years. They took out patients that had prevalent ASCVD, so if they had a history of MI, a transient ischemic attack, stroke, peripheral vascular disease, or any sort of coronary revascularization, those patients were excluded. They included patients that had cancer, dementia, and paralysis because they wanted their patient population to reflect a more accurate practice setting. If a patient had passed away within 150 days of entry into the cohort, they deleted them from the data because they found that a patient needed to be on a statin for at least 2 years to see this benefit, and that would not have met the time period. 2 to 5 years for benefit is what they base that recommendation off of. There were a total of 326,981 veterans who were eligible for participation, and 57,178 became new users of statins during that time. That was the group that was assigned to statins, and the others were non-statin users. These were patients that were prescribed to a statin for the first time. The mean age of patients was 81.1 years. The range of ages was 75 to 107 years. 91% of the patients were white, and 97.3% were men. This also impacts the generalizability of the study results to the general patient population. Simvastatin was most commonly prescribed, and they found that statin use was significantly associated with lower risk of all-cause mortality and cardiovascular death. They saw this at 2, 4, and 6 years. For these patients, it seems reasonable based on this evidence that patients would be using a statin for primary prevention at age 74 years or older for patients that meet this criteria. This is looking retrospectively at claims data. There are some limitations related to that as well. It's not clear if everyone was captured that could have been captured. When we look at limitations of the study, we also consider that the statin that's being prescribed is not the most commonly used right now in practice. Although statin benefit is generally seen as a class effect based on intensity, that might be something to consider. The other article that was published in July of 2020 is Association of Statin Use with Disability, Free Survival, and Cardiovascular Disease Among Healthy Older Adults. This was a secondary analysis of a SPREE trial. The SPREE trial is aspirin in reducing events in the elderly. This was for community-dwelling adults who were either 70 or older than 70 years of age. but they didn't have a lot of patients enrolled that were over 85. This patient population was primarily Caucasian, but it did have a more equal distribution of men and women than the previous study. The author's conclusion for this study was that among healthy community-dwelling adults greater than 70 or equal to 70 years of age, statin use may be beneficial for preventing physical disability and cardiovascular disease, but not beneficial for preventing disability, free survival, or avoiding death and dementia. Future clinical trials are needed to confirm these findings. This was a secondary analysis of the SPREE trial of aspirin in the primary prevention of cardiovascular disease. That trial is the one that formed the basis for the recommendation in the Beers criteria that says to use aspirin with caution in patients who are older or over 70 years of age for primary prevention. That is the trial that this came from. There are some barriers to looking at a secondary analysis. We're looking at data from the perspective of it not being the primary outcome that the researchers were studying, but the researchers did a good job of trying to account for all these different criteria in making their findings. While it is not necessarily a finding that's going to change the way you practice with this type of level of evidence, it adds to the discussion. It also points toward the importance of having more definitive answers to be able to determine whether patients should remain on a statin for primary prevention as an older adult.